All right, we are here, and it looks like we have quite a few of the attendees already. This is good stuff. All right. Well, welcome everyone. Let me just get centered here, and welcome to tonight's webinar. I'm going to turn on and share a few slides here. Do some housekeeping. Well, Dr. Saka and Hasty will be doing tonight's presentation. Oh, guys are gonna get to see this preview of my housekeeping. So welcome to Clinical Grand Rounds Perspectives from an Optometrist and an Internist. You are at the right spot. Some housekeeping. This course is being recorded. There will be a replay sent tomorrow via one of the email links. You should get, in a sense, 5 emails. There were 3 for today, the one that you registered with, and then 2 today, and then you'll get one about 2 hours from now. It will have a survey in it. Please complete the survey. We need that for the regulatory boards that are out there. And then you'll get one tomorrow that will have a replay and the survey in there. The replay will only last for a couple weeks, and then it goes away. But we do house all of our webinars on our YouTube channel. So if you just go to YouTube and do Optometric Education Consultants, you'll see our previous webinars there. It will take me probably till about Monday or Tuesday to get this one on there. So give us some time for tonight, but you'll have the replay link. You'll need your unique password to do that. We did mention that there will be a survey sent tonight and tomorrow. Please complete that. It is a requirement that we need for the regulatory boards. COPE has been great all this year to allow us to use these live webinars. So please help us out by helping them out. One of the best things that you can do right now is decrease your bandwidth. If you got 2 screens open, watching some football, you got someone in the house really stealing some bandwidth by playing movies or playing video games, that's going to steal the bandwidth, and really this is cloud-based. It's going to slow it down. You might get asked to connect or to reconnect. Only do that if you lost total connection. Vanessa is our conference administrator. She will send your information to arbo/cope. She will upload that. I'll probably get out the attendees tonight to her. She'll probably do it Monday or Tuesday. However, COPE is busy by doing all these webinars. That's where the delay is. No fault on them. They're very busy. You'll probably get the credit in about a week to 10 days. We will also email you a certificate to the email that you registered with. So there's going to be a kind of a double way of getting credit. We'll upload it to arbo/cope OE tracker. I know some states don't do that and they require a certificate. Again, you're going to get a certificate. Now, let me just show you a little something here. This is me. I'm going to turn on a little bit of whiteboard, and you're going to see here that there's 3 little dots on your screen in this red. I'm circling it right here, these 3 little dots in this red square. If you click on that, it either expands it all the way out, or if you click on it, it shrinks it. And here it is on this screen here. This is 2 different types. These 3 little buttons in this red spot are important because now that lets you see all the different types of panels here, which is regarding the chat and the polls. And right now, I'm going to go to Files, and I'm going to hit Share. And I'm sharing the handout. So in order to get to the handout, you have to be able to have that on kind of the front down version. Those 3 little dots in that little red box expands and contracts, and that's going to allow you to do the polling questions, which is important for this live and interactive for us to be able to do that. So I'm going to turn that off now, and I'm going to do a test polling question. So make sure you have it shrunk down. I'm going to start the poll. I'm going to click that we're going to share the answers. I'm going to publish it. So let's practice a poll here because we have about 5 or 6 polls that we're going to be doing during this webinar. And I see people already weighing in. And the test poll is, my practice is, due to COVID, not yet open for emergencies and urgencies, open full-time with a reduced schedule, open and pretty much back to normal, and open and busier than before COVID-19. And I'm going to give it some time. I see people weighing in. Good. That's exactly how it's done. And as you guys are weighing in there, remember the chat box, which you'll see there, is for questions. It's easy for me tonight. I can watch and listen. I like when I get to do this. I will monitor the chat for questions. Please type your questions there, and if it's appropriate, I will, at the time, let Robert and Joe know the question. They can answer it. So I'm going to end the poll. You guys did great there. It looks like, Joe, this has been pretty cool. We've been doing these since March, and 19% are full-time with a reduced schedule, and about 49 or 50% of the attendees are back to normal, which is great. And then just what we've been seeing, a trend as we keep doing these, 29% are busier than ever, and just a few are not open yet, 1%, and there's no one out there for urgencies and emergencies. So that's great. It's good to see that all happening out there. So I'm going to say thanks for attending. Let's get started. Joe, I'm going to turn it over to you. I'm going to stop sharing my screen here in a second.
All right.
And it's up to you. And I'm just going to make a real basic introduction here. This is my partner, Joe Saka, and he's awesome. Pleasure to work with. Well-written, worked at Nova for 28 years, is now relocated to Sarasota. Joe, that's all I'm going to give you tonight. Let you take care of your friend, Robert.
Thank you. We're very happy to invite a friend and colleague, Dr. Robert Hasty, to do this webinar with us. You know, he attended the University of Miami, and he went on to get his Doctor of Osteopathic Medicine at Nova Southeastern University's College of Optometry. I'm sorry, I'm so used to say that. Nova Southeastern University College of Osteopathic Medicine. That's where he and I had met. He trained at Mount Sinai Medical Center and in internal medicine, and he was resident of the year there. He also served as chief internist, chief resident during his training. He began his career as a hospitalist and internist for Cogent Healthcare in Fort Myers. He soon became associate lead physician for Cogent Healthcare, and then left to go to a calling to become an academic physician. He joined Nova Southeastern University's College of Osteopathic Medicine in 2005. He was a founding program director at Palmetto General Hospital's internal medicine residency, and he developed other graduate medical programs there. He was a recipient of numerous teaching awards while at Nova Southeastern University's College of Osteopathic Medicine. And he left there, he went to Campbell University College of Osteopathic Medicine, where he created 383 residency programs, residency positions in 20 programs. And he has been instrumental in training the next generation of osteopathic physicians. He became the founding dean and chief academic officer for Idaho College of Osteopathic Medicine, which was Idaho's first and only medical school. And he is board certified in internal medicine and is a fellow of the American College of Osteopathic Internists. So with that, very happy to welcome our friend and colleague, Dr. Robert Hasty.
Thank you, Dr. Saka. It's a pleasure to be here.
All right, so what we're going to do is we're going to talk. Robert and I have done numerous grand rounds together because I think it's really instructional and very, very beneficial to work with other disciplines. And I think outside of probably ophthalmology, internal medicine is where we interact most with other professionals. So what we're going to do is talk about some optometric cases and get an internist perspective. And then when you're done you're tired of hearing me, I'm going to turn over to Robert because he is working frontline COVID care, treating hundreds of patients in the COVID ward in a major hospital. And I think we all want to hear what he has to say. So with that, I'm going to turn my screen share on. Let me find which one I want. Yeah, I think this is good. And we're going to start off here with our clinical grand rounds, perspectives from an optometrist and an internist. I've got my disclosures. I'm in a number of speakers, bureaus, and of course with Greg, I own Optometric Education Consultants, Robert has no disclosures. So with that, let's launch into a case. And this is a case where Rob and I actually had the first opportunity to work together. And this is what I call the world's best disc hemorrhage. He was a 33-year-old dental student, white male dental student at Nova's dental school. And he came in and he had occipital headache for about 4 months, and he was having some visual aura with his headache. And it worsened when he stood after sitting for a while. He felt sleep helped him. He used over-the-counter analgesics. And he had no vision loss, nausea, double vision, pain in eye movement, no behavioral changes. I think, Robert, he went to you first, and you did an age-appropriate physical, which is all normal, then asked him to come see us.
Yes.
So when we saw the patients, I actually saw it with my resident. Patient was 20/20, a little nearsighted. Neuroocular screening was normal. Everything was fine. He had nasally and obliquely inserted optic nerves. But one thing that we noticed, and there's no disc edema, these are just full nerves, small nerves. He actually had a relatively small hemorrhage near the optic nerve, and this is why my resident called me over to consult on possible glaucoma. And there's clearly no thoughts or evidence of glaucoma here. And by the time I had gotten over there, my resident had done a visual field. And the visual field came out that looked like this. And Greg, that brings me all the way already to our first polling question.
Okay, it's published. It says here, a 30-year-old reports chronic mild daily headache. Visual field and ocular exam are normal. What to do? The poll is up there. You can see, you can put in your answer that says refer for MRI, refer to CAT scan, send to an internist, send to a neurologist, recommend over-the-counter analgesics. Robert, since we have a little break here, if you want, up in the upper corner there's that first blue box. If you want to turn on your camera, Joe's on. I'm sure they would love to.
Actually, Greg, we've been texting back and forth. It knocks out his audio, so he's going to go blank screen.
Okay, that's fine. Mm-hmm. So with that being said, the polling question here is refer for an MRI is about 9%. We have refer for CT at 2%. Send to an internist at 39%, 40%. Neurologist is 42%. So Joe, the tie is internist, neurologist. It keeps going back and forth. We have an internist on the webinar tonight, so if I was voting, it doesn't allow me to vote as being a moderator. I'd go with internist, but we'll pause it there. 11% for MRI, 2% for CT, and equal for internist and neurologist, and no one bit for over-the-counter analgesics.
Well, going into the story, by the time I had consulted with my resident, she had spoken and actually had made an arrangement for a consult with a neuro-ophthalmologist. And that was about 3 weeks later. And I wasn't going to dissuade them from doing that. And I said that was fine. And it just so happens I was walking through the university later that day, and I ran into Robert and said hi. And I mentioned this case, and I said, there are a number of things that we can do before he sees a neuro-ophthalmologist. Do you want to co-manage the patient with me? And Robert said, yeah, of course. And I don't know if you remember, Robert, we stood in the breezeway and we kind of bantered back and forth as to what to do with this person who had this hemorrhage. So Robert, I'm an optometrist, and I tell you, this headache guy has a small hemorrhage, and we should probably start looking for things. And when we start looking at blood work and infectious diseases and infiltrative diseases, what comes to your mind?
So, obviously, some of the things that, you always think of with, headaches, especially acute headaches, it would be the standard, headache type of syndrome, such as everything from a migraine headache to tension, common tension headache, just to a common headache. Obviously, with chronic headaches, you think of everything from intracranial tumors, masses, malignant brain tumors. You also think of things such as medication-related caffeine withdrawal headaches. You can certainly think about infectious etiologies. Typically, things like meningitis, encephalitis, you think are more for acute headaches, but certainly you can have some encephalitides can cause, chronic headache or I should say subacute, headache syndromes. And of course, collagen vascular diseases, rheumatological diseases can be associated. One that comes to mind is lupus cerebritis can cause, a headache type of syndrome. And of course, the workup kind of falls from that. So, for acute headache, young person with acute headache, you want to try to characterize it. If it's a hemicranial headache, you always think of migraine headaches. For a hemicranial headache lasting less than 72 hours, for a headache that's lasts, that's usually bilateral, can be occipital in nature. You think of something like a tension headache. With the chronic headaches, you do think of things, if it's a morning type of headache that wakes the person up in the morning. Certainly tumors can be associated with that. If there's a positional changes, you think about a mass effect like a tumor. If it's a headache that gets better as the day goes along, but you wake up each morning with it, you think about things such as obstructive sleep apnea can be associated with it. Sinusitis, acute sinusitis, and even chronic sinusitis can be associated with morning daily headaches. So those are some of the things that come off the top of my head when we talk about headaches.
And which headaches really bother you? I mean, which ones are the ones that you're going to investigate more thoroughly?
Yeah, so so first of all, when there are obviously the biggest ones I worry about is an acute headache that's associated with fever, nuchal rigidity, or neck stiffness. If they have photophobia, but it's not just that typical hemicranial headache that they typically experience with a migraine headache. They don't know that they have a migraine headache. Those are certainly worrisome for infectious process. Change in behavior is a warning sign for certain types of encephalitides, but it could also be associated with intracranial mass effects, headaches. If they do have any type of neurological focal findings, such as weakness in extremity, upper and lower extremity, certainly that could be associated with a worrisome headache. Headaches that do wake you up in the morning, you do have to exclude malignancy, so that could be a certain worrisome sign. Positional related headaches, tumor effect, weight loss, any recent weight loss. Obviously, you got to worry about any type of malignancy. So those are off the top of my head, those are some of the very worrisome headaches, and those are red flags. New onset headache in an elderly person, that have never had headaches before, that's also an important red flag.
When you look further and you're going to neuroimage, what is your preferred testing?
So MRI is really the way to go. Now, if you're looking for a patient with a new onset, worst headache of their life, like you'd expect with a subarachnoid hemorrhage, then you have to proceed with a CT scan of the head without contrast, because you can get it quick. If you get it without contrast, it's not going to obscure the blood, and it has a pretty good sensitivity for things such as a subarachnoid hemorrhage. So the CT scan without contrast would be the test of choice for emergency. But for any other type of headaches, anything that could be associated with a intracranial malignancy, anything that's, when you're working up patients with multiple sclerosis, when you're working up patients with stroke, after you get the initial CT scan of the head in those stroke patients, really the MRI is by far, the test of choice. And, if you're looking at just stroke, you can probably get away without the contrast, but the with and without contrast MRI gives you such incredible visibility and can differentiate the vast majority of intracranial lesions, and issues associated with certainly with chronic headaches, and to rule out a lot of serious conditions. Obviously, a lot of patients nowadays do have devices such as pacemakers that would contraindicate their use of MRI. So we sometimes still have to do a CT with contrast. And a CT scan of the head with and without contrast is almost as good as an MRI nowadays, but it's still not quite as good as an MRI. So MRI, I'd say from an imaging standpoint, is by far the best initial imaging test for a chronic headache.
One thing I remember, or several things I remember about this patient and this case, it wasn't a hemicranial headache. It was just a nagging headache. And when I remember when we were talking, you had done a neurologic exam, and he was perfectly fine neurologically. I know we were talking about a lot of the serology and the infectious diseases, looking for syphilis, Lyme disease. And I remember we almost ignored the headache part, and I remember saying we'd be kind of crazy to do all the serology without making sure there's nothing up there. And you said, "Oh yeah, that's a good idea, and we'll get an MRI as well." But here's a person, good vision, good visual field was normal, and it turned out he had a very large intracranial mass in the frontal parietal region that was more on the right side. I think it was causing a midline shift. Do you remember all this, Robert?
I do. So I remember, actually, I remember very well. It was a Friday night. We'd ordered, an MRI, during that week, based upon our initial conversation. And, of course, you get a call from a radiologist at, 9 o'clock on a Friday night. It's never good news. So, and I do remember, this large intracranial mass, and it was, quite large. It was, worrisome for intracranial tumor, as you might suspect. And of course, I remember having to, call this young man up on a Friday night. And there was a little bit of a mass effect associated, with this. So, which would indicate that the patient would be at risk of, seizures and those type of things, which is, it was actually quite impressive to me, the fact that we, didn't see more on neither the optometric examination or, my neurological examination. Of course, I did get some, a little bit more history from the patient at that point. And of course, when patients find out they have a brain mass, sometimes they give you a little bit more. And he did report more of a positional nature to the headache, which wasn't super obvious up front.
Yeah, and I remember when we've been presenting this case, and I remember one time you had followed up and said that he had surgery, and I think he underwent treatment, because they weren't quite sure exactly what type of tumor was there, and somewhat indeterminate. But he ultimately came back. He went to dental school, finished dental school, and had a successful practice in Tampa. And I remember talking about that a number. This is a very good learning case for my residents, that a normal visual field doesn't mean you can't have a brain tumor. It just means it isn't affecting the visual system. And we were talking about that, and I shared the story and how he went back to dental school and had a successful practice in Tampa. And I kept saying, and I realized, I really should actually look this up. And I put his name into Google, and the first thing that came up was a link to his obituary, because he died about 5 years after we saw him from brain cancer.
Yeah. It's a very very unfortunate case, but I'm glad that we found it as early as we did.
Yeah, I mean, it at least gave him time to get his affairs in order, I would imagine, and 5 more years with his family. Greg, are there any questions out there?
Let me look. So my question was, and since I have the ability to do that, is in your polling question, would be referring to an internist? Is that what you were looking for?
I wanted to see what people, how quickly people would work up a headache. I love working with internal medicine. I wish Robert was closer to me. I'd be working with him a lot more, because otherwise, had I ordered that MRI, I'd have gotten the call Friday night, and not Robert.
Right.
And it would have been a heck of a lot harder for me to get him admitted to neurosurgery that same night, which is what Robert did.
Gotcha. So here's a question. It says, do you ever consider MRA/MRV for headache patients, or typically just order an MRI with and without contrast? So Robert, I guess I'll let you go that. And then Joe, I know you do a lot of neurology. You can then give your sense. So.
Yeah, so that's a great question. So certainly in the MRA, looking at the arteries, and MRV, looking at the venography, those are excellent tests for certain conditions. So certainly with the MRA, you really can't get a better view of the neck veins and the intracranial veins better than you can with the MRA. And so I would say that that's typically more of a step 2 type of a test. So say, for instance, even if you're looking at some of the initial things that can, such as a carotid dissection, that can give you a headache, and it actually can present as even a unilateral headache, MRA, would be a tremendous test. And obviously in the setting of acute stroke, you do want to image the carotid arteries, and tests such as MRA or CTA are really just terrific, and I order them pretty frequently, in those conditions. MRV, we don't order a whole bunch of MRV. Now we're starting to with some of these COVID, residual patients, just because, we are getting, more, clots in the venous system that go up to the brain. But, the intracranial venous clots, are relatively rare. And I can say over the years, it's not something that, you even see, once a year as an internist. It's something that I've probably seen, practicing a lot of hospital medicine over the years and taking care of a lot of patients, both in and out of the hospital, mostly in the hospital. It's a rare phenomenon. I've only seen, probably 2 or 3 times. And, one of them was actually on my service. The other one were on my partner's services. So those are, doing an MRV is, an exceptionally, rare requirement, but a case. But of course, it would be the next step, and when you are suspecting, venous clot,
And I agree. MRV and MRI both need to be done for cases of suspected papilledema. So we have to, recommend that, because you can get a venous sinus thrombosis, a transverse sinus thrombosis. And MRA is if you're looking for an aneurysm, for us. And that's usually third nerve palsies. So we're looking for, if to find an A, you need an A. So you have to have an MRA for intracranial aneurysms. That's what we're looking for. Well, he's a 74-year-old white male who presents with the worst headache of his life. Okay, this looks like it's going to be a headache lecture. He saw a number of people at a Veterans Administration hospital, including a physician assistant, an ER physician, a cardiologist, a nurse practitioner, and even 3 optometrists over a 3-week period of time. Now, his histories included over the 3 weeks eye ache, jaw pain, scalp pain, facial pain, somnolence, to the point where he fall asleep while eating his food, malaise, and a jaw claudication. He was first diagnosed by the PA as having temporal mandibular joint dysfunction. Was given an NSAID, came back a couple weeks later, didn't feel any better, and they found a tick on him, and he was in an endemic area, so now he was diagnosed with Lyme disease. I think put on an antibiotic, probably doxycycline. They actually wrote in their vasculitis, such as temporal arteritis, highly unlikely, it said not GCA, but somebody ordered a said rate and C-reactive protein, and I think it may have been one of the optometrists, and it came back elevated, but there's no indication anybody ever reviewed the findings, and the end result was, he went bilaterally blind from giant cell arteritis and anterior ischemic optic neuropathy. So, this is an acute infarction of the posterior ciliary circulation with severe optic nerve dysfunction and a pale swollen nerve. Now, giant cell arteritis and polymyalgia rheumatica are certainly risk factors, and it is typically a disease of the elderly. But once you get above 50 years, it's always going to be on the menu. And the issue here is a high risk of bilateral involvement here. Now, in my practice, a colleague of mine asked me to look at a case for her on Friday, and it's a patient who had pretty clear it's a non-arteritic ischemic neuropathy. But the issue is he also had a diagnosis of polymyalgia rheumatica. So, Robert, why don't you talk about PMR and GCA from the internist point of view?
So, typically, they usually present to us with a temporal pain, unilateral or bilateral temporal pain, and it's obviously it's over the temporal area, usually severe pain over time. Some people will just complain of nagging pain. I recently had a lady here that I took care of in the hospital setting that had been having this for some period of time. And it was about over a year period. This chronic headache had been treated with analgesics as an outpatient for this pain. And then, of course, she presented to us with acute blindness in the hospital setting, which required inpatient IV corticosteroids, high dose. So yes, and as you mentioned, Joe, these are typically not your pediatric population by any imagination. Always older patients. Although now that I'm getting a little bit older, I don't consider that old, but certainly each decade over 50, you start to see a little bit more. So certainly not the younger patients.
Interestingly, there was a very well-known neuro-ophthalmologist named Dr. Andy Lee, and he was talking about this at a conference where we're working together. And he said, remember, chair, hair, stare. You say chairs, tough for them to get out of the chairs. Stare, tough to walk upstairs. Hair, it hurts when they comb their hair. And I also like to add in their fair. They tend to be people of Caucasian descent more so than patients of African descent or even Hispanic descent. Now, I come across this in kind of two ways. I can have a person who is elderly, has a gangbuster history, and has acute vision loss from an artery occlusion or ischemic neuropathy. And that's a true emergency, and that's a person I'm going to be sending right to the emergency room with very detailed instructions of my thought process and what needs to be done. I mean, when that happens, how quickly are they going to act on it, and will they get it right?
I think it's one of those conditions that you really don't want to miss, right? Because the stakes are pretty high in this condition, and certainly when you do suspect a patient with temporal arteritis, you want to try to confirm the diagnosis because you're talking about committing the patient to several months of treatment, and just giving the patients steroids is not necessarily the answer, because that's the only way to really prove the patient has temporal arteritis is to get a temporal artery biopsy, and to do so with temporal arteritis, it's typically an ENT consultation, Some general surgeons do, some vascular surgeons will do a temporal artery biopsy, but typically it's an ENT type of thing, and it's a simple little procedure actually, where they just go in, they just take a little little sample of the temporal artery, and to do it, and obviously you want to try to get the side where they're having the most symptoms, but you can get the other side if there's some confounding reason why you can't get the side where they're having the more prominent symptoms, and it's really kind of the test of choice, and you can go ahead and start giving them steroids prior to getting the biopsy, but you don't want to wait too long, because if you can get them under remission with the steroids, you could actually camouflage underlying temporal arteritis, and you may come back with a false negative temporal artery biopsy on the patient. So it is important to consider early temporal artery biopsy in these patients.
And the other patient profile that I'm going to see is a person who comes in, an elderly patient, often the fair complected, elderly, who has an age-appropriate normal examination, but doesn't feel well, is not thriving, and complains about headache. Now, I can order a sed-rate C-reactive protein and platelets, but more likely than not, I'm going to work with the patient's internist and send the patient to the internist and say, here's what's going on. Please evaluate and act appropriately for temporal arteritis. So if I send that to you, Robert, what's going to happen?
So first of all, I think that we have to act quickly. If we truly think it is temporal arteritis, we are going to get a sed rate, a stat sed rate. We'll get a CRP and some other inflammatory markers as well, on the patient. And if we truly believe it's temporal arteritis, the answer is actually to start steroids and to get a biopsy, ENT biopsy. I'm getting to a point now where, I think that, certainly if the patient's having visual loss from it, trying to do this outpatient is very, very difficult. And I'm to the point now where I truly think, given the constraints of sometimes, the delay in care, and especially now that we're talking about, during the COVID period of time, where sometimes outpatient workups and everything aren't as efficient as they normally are. It's very easy, in the hospital setting. I mean, we can get all the stuff back in about an hour or two. I can get the patient admitted, put them on steroids, and get an ENT consult to do make the patient NPO after midnight for a temporal artery biopsy the next morning. So I'm starting to think that, certainly having that conversation with the the internist, of course, the severity of the illness, whether or not the workup's going to be done very quickly, or if it's just easier just to get the patient either as a direct admission or even as an ER referral, just to get it treated quickly.
But, I'm not talking the visual loss, but I'm just talking the older person who comes in maybe for a glaucoma follow-up and mentioned she's been having headaches for about a week.
Okay, yeah, for that, I certainly think, that's kind of like the perfect referral, for an internist, just to kind of see in their office.
Excellent. Greg, anything else going on there? Any questions?
Nope, everything looks good. Everything's nice.
I mean, let's do polling question number 2.
Okay, it's published, and it says a 72-year-old woman complains of a new onset daily headache for the past 2 weeks. Her exam is normal. What do you do? There are 4 choices. Refer immediately to the ER. Send to your internist. Send to a neurologist. Recommend over-the-counter analgesics. So this is a 72-year-old woman complains of new onset daily headache for 2 weeks.
And a normal examination.
Normal exam. What to do? All right, people are rolling in here. Give it another minute or two. No one is recommending over-the-counter analgesics. No one is referring to an emergency room. We have a lot of people sending to an internist at 5%, and 25% is going to a neurologist. So 1 in 4 are doing neurologist, 3 out of 4 are going to an internist.
And that's kind of what I'm going for. I've already said we need to be working with internal medicine probably a heck of a lot more than we already are. As Robert said, these patients probably do best in the hospital because at least that way they're getting it. They're going to get it. But Robert, what's going to happen? Several months down or 6 months down, where they're still on prednisone. I mean, what issues do you have with steroids?
So particularly with the high dosage of steroids, and it says 1 to 2 milligrams there. It should say actually 1 to 2 grams of steroids. I mean, these are massive amounts of steroids. So certainly initially, especially in our diabetic patients, the blood sugars go through the roof. So you have to follow the sugars extremely carefully, and your diabetics, and then of course long term, you have to worry about the sugar. Even in patients who are pre-diabetic or not diabetic, you give enough steroids to even the average person without diabetes, and you're going to see those sugars go up over time. What you're also going to see over time is you're going to have some immunosuppression. The immunosuppression actually takes some time to really truly manifest, certainly in these high dose patients. But when you're talking about giving the dose requirements for GCA, I mean you got to start thinking about things like pneumocystis pneumonia pneumocystis carinii pneumonia prophylaxis, like you do in HIV patients. You have to think about certainly all their standard immunizations, making sure that they get meticulous care, and having a very low threshold to work them up for any type of infectious etiologies. You also have to worry if you put anybody on steroids for more than 2 weeks. You have to worry about adrenal insufficiency, because what happens is the adrenals can actually kind of shut off, and if you try to abruptly stop the steroids after a while, the patient can develop basically a crisis where they become hypotensive and really have all sorts of problems. So more than 2 weeks, you have to think about tapering quickly or slowly I should say. Also, for long-term steroids, patients will have proximal muscle weakness, and actually this can happen actually sooner rather than later. They'll get very weak. They have difficulty even getting out of bed. Sometimes if you have steroids, and this could even be true of these patients that we treat for much lower doses of steroids than we do with the GCA. And then, of course, you have to think about bones too. The osteoporosis does present itself in patients who are even in moderate to long-term steroids, and can be very, very severe. So certainly not not the panacea of all drugs, and certainly a potentially dangerous drug.
Now there's a medicine out there. It's been pre-approved for other things, but it's recently got an approval for giant cell arteritis. It's Actemra, or tocilizumab, which is a IL-6 inhibitor, and they're using it not to treat the disease, but to reduce their steroid taper, because these people will be on 6-12 months or more. Do you know anything about that, or any experience with that?
So I don't have any experience treating it in the setting of GCA, but tocilizumab happens to be a drug that we're starting to use with our COVID-19 patients, especially those who are in an inflammatory storm with COVID-19. But I don't have any experience with GCA.
Yeah, we were doing a conference live actually in Minnesota. And we had a person who did neuropathology fellowship, and he was saying that people are using it, and it's really getting them off the steroids, and it's reducing some of the steroid complications. But it's very expensive, and I think for GCA, it's only approved to be used, he said, by a rheumatologist, and people are afraid to get them off. They're just afraid to take them off for what might happen. So I think there's a lot more that we have to figure out for that one. Well, here's one called "The Medicine Makes Me Sick." 52-year-old female, hypertensive and diabetic for a number of years, doesn't know her medicines, poorly controlled, not compliant, has a blood pressure 157 over 109, and has some findings consistent with a kind of a dry not diabetic, but a true hypertensive retinopathy with these focal cotton wool spots in both eyes and some superficial hemorrhages. Tell us about this patient, Robert. This is sort of like the nightmare patient that we see. They're an ischemic vascular disaster. We have blood pressure, what we see, 157, 109. I'm gonna see this patient, and there's retinopathy, and I've seen it, and there's nothing malignant about this, but I'm gonna be sending this back to the internist, or if she doesn't have an internist, I'm gonna send it to an internist that I work with. What happens when you get this patient?
Yeah, so obviously this patient has a number of different issues going on with her, right? I mean, you have diabetes that you got to get to goal. With now with the hemoglobin less than 7, you have hypertension with that is poorly treated. Certainly that needs to be down to goal. Ideally less than 130 over 80 in this patient with diabetes. Certainly focused on other risk factors. Prevention of coronary artery disease would be certainly an important consideration. Statins for this particular patient would be indicated, and nowadays we'd probably go based upon the risk factors of this particular patient, maybe high dose statins. Things like either very strong statins such as either atorvastatin, rosuvastatin. You may even go to moderate such as simvastatin on this patient. Of course, there's always this argument: should you put this particular patient on, adult low dose strength aspirin? The old baby aspirin, 81 milligrams a day, probably would be indicated. Of course, exercise. Would be indicated in this patient once blood pressure is controlled, and also judicious management of the weight. DASH diet for the hypertension, but in this particular patient, you want combination of low salt diet as well as carbohydrate controlled diet for the diabetes.
So I see this patient. She hasn't been to her primary care physician in who knows how long. She doesn't remember who it is. So I'm going to refer it to you. How much of an urgency is this, Robert?
So, with the hypertension, and I believe it was, if I remind me of the blood pressure on that previous slide. So 157.
109.
Yeah. So technically this is hypertensive. I would say it's a more of a hypertensive. Urgency. It's on the cusp of being a hypertensive urgency in this particular case. So this is the type of patient that does not require any IV, any hypertensives. This is a patient that does not require any inpatient treatment or anything like that. This is not somebody that you would send to the emergency department. It is somebody, however, that you would initially treat with 2 drugs right in the office with very close outpatient follow-up.
How soon do I need to get them to you?
With this blood pressure, I'd say like the next day.
Okay.
That day. That day, the next day.
Okay.
If it's in the afternoon, I'd say the morning. Morning after.
Greg, how about a polling question?
All right, I think I can do that for you. Let me get the polls turned on here. Poll number 3, we just published it. A 56-year-old man has blood pressure of 147 over 109. So let me say 147 over 109. and has mild retinal hemorrhages and a cotton wool spot. These are in both eyes, the retinal hemorrhage and the cotton wool spot. What do you do? Refer immediately to the ER. Send to the internist. Send to a neurologist. Recommend weight loss and exercise. I think we can always recommend weight loss and exercise to everyone, but let's not go with that one. All right. Answers are rolling in, and just kind of talk through it and give everyone a chance. Remember, everyone, the screen has to be shrunk down. That's those three little dots that I showed at the beginning in case you were late. Those red box rectangle with the three little white dots in it, that's what expands and collapses. Hit that and it will shrink down. You'll see the polling questions. I will be launching another handout. Remember, the handouts are in the files. All right, Joe, I think that's long enough. Enough people are rolling in. I'm not seeing much movement. Looks like 91% said internist and 8% or 9% said go to the ER.
All right, very good. Well, let's make a twist. He's a 47-year-old male who is obese. He's 400 pounds. I think that's kind of being kind. He's had headaches for 3 months, vision reduction for 2 months. He's about a 20/50 and his blood pressure is 212 over 155. And now we have bilateral disc edema. We have exudation into the macula. We have superficial hemorrhages. We have dilated retinal vasculature. Let's hit polling question number 4.
Okay, and remind me, there is a question regarding GCA at some point. Polling question number 4. It's going to be published right now. Okay. 56-year-old man has blood pressure 255 over 132 and has retinal hemorrhages, cotton wool spots, and disc edema both eyes. What would you do? This one is refer immediately to the ER, send to an internist, send to a neurologist, recommend weight loss and exercise. 255 over 132. Go to the ER, to the internist, neurologist, exercise, and weight loss. Well, Joe, looks like most people are gonna looks like no one's going for the weight loss and exercise. No one's sending to neuro. Small percentage, 3%, going to the internist, and the rest, 96%, refer immediately to the emergency room.
Robert, what are your thoughts here?
Yeah, so the audience got it right. This is a guy that needs to be on, IV antihypertensives. You do initial treatment in the emergency department, try to get his blood pressure down. If they can't get it down, within a few hours, then that's an ICU admission.
How much help is it for you? If I send you this information, here's blood pressure 250 over 150 say. In the office, patient has actual papilledema. This is, for us, this is a diagnosis of malignant hypertension, retinopathy. Does that help you as a primary care physician for me to tell you all this information, or do we just ship the patient right away when we take the first look at them?
Yeah, I mean, I think that probably the best relationships are ones where we really work as a team as much as possible. More information, less. And and we're all focused on the same thing, which is provide the best patient care possible. So that this is like one of those perfect examples where you text your you call up your internist friend and just give them a quick little scenario, and then they can kind of give their advice, and of course and they hear your what's going on, and trust me, the average internist or primary care physician or hospitalist knows very little about the eyes, and so we listen very, very carefully to everything you say to us related to the eyes. So we appreciate it. But yeah, this would be a perfect one to, call up. And, of course, this one, probably more of a call to your, ER, colleague, and they'll get the patient treated quickly.
What's his prognosis, Robert?
I think that this particular patient with, just treating, the hypertension, will do extremely well. You'll be able to get the blood pressure. You actually don't want to get the blood pressure corrected too fast, but you at least give a reasonable reduction in the blood pressure over the next several hours. And, and then eventually, you'll have a goal within the next few days to try to get the patient down to, near normal, blood pressure. Yeah, this patient's going to be on multiple, blood pressure, medications to get them. Certainly this patient probably has underlying sleep apnea as well. That needs to, be assessed in this particular patient. So probably a sleep study will be, needed for this patient. Anybody with resistant or hypertensive emergency and obese patient, you always have to consider whether or not there's an underlying sleep apnea present as well.
Excellent. Greg, you had mentioned that there is a question on GCA.
Yes. Would you recommend running GCA testing on all patients greater than 55 years old and complaining of a recent onset of headache? ? For the purpose of this question, let's assume that they have no GCA-specific complaints and have an exam findings that are normal.
Yeah. I don't know if you want to take that or you want me to, Joe.
Go ahead.
So absolutely. So I think that the answer is that we definitely need to, treat this patient with this new onset, headache. So I'd say anybody, older than 50 years old with a new headache needs to be evaluated and also needs to be ruled out for GCA.
And Robert, while we have you, and I'm kind of in the background here, but in the back of my mind, when we're doing a blood work for GCA, we do a complete blood count, we're doing a C-reactive protein, and we're doing a SED rate. And on the complete blood count, we're looking at hemoglobin. If it's down, for some reason, I believe platelets go up, SED rate is up, and C-reactive protein. So everything's elevated other than the hemoglobin. Are those still kind of the four findings in kind of blood work that we're looking for, or is there something else I can learn from you tonight that we can look for on blood work?
For screening for the purposes of GCA, that's absolutely the perfect perfect set of blood test, and what you said was accurate.
Well, there are a number of cases that Robert and I go over. But I think the important thing here is not to listen to me, but to listen to Robert. And we're in a very special time. So what we're not going to do now is we're going to shift over a little bit. Greg, are you seeing my screen okay? Robert, did you see the screen? Are you still seeing the screen? I shifted the presentation.
Perfect.
Okay.
Yep, everything's good, Joe.
So what we're going to do is we've got the opportunity. We're in the midst of this pandemic. We are not clear exactly what's happening. We can believe nothing of what we hear and only half of what we see. I think it's a treat and honor for us to have somebody who's in the hospital treating these patients tell us what is really going on. So Robert, we did have some technical difficulties, so I have to run this from my computer. So just give you a little nod every time you want me to advance. But I'm anxious to hear about your experience caring for COVID-19 patients.
And Joe, just so everyone knows, in the files tab of everyone, again, that's that little red button is important. Make sure you're not in expanded mode. And if you go to files, I just shared the handout for this. So I was able to do that. So if you guys want the handout, just download it and it will be there. And Joe or Robert, I just wanted to do that housekeeping. Take it away, please.
Great. Well, thanks so much, Greg and Joe. Yeah, so I've had the honor and pleasure of taking care of I think at least a couple of hundred inpatient COVID patients at this point. Despite what you may hear at the media or otherwise, this is a very real disease. I've had to, sign the death certificates for many patients with COVID-19. We have seen significant morbidity. I've had a 32-year-old lady with 2 children pass away from COVID-19. Actually, 2 weeks ago today, I did a code blue resuscitation in the hospital on a 56-year-old man with COVID-19. So it's very significant disease, and of course, I'm sitting there in the hospital side of things, so it's not really affecting the outpatient side of things. And when we talk about of course, the inconveniences of wearing masks and doing the social distancing and everything, I think that if you could spend a day in my shoes when I'm on the COVID ward, you would appreciate some of the challenges. I never forget. I sent home a guy about 2 months ago with 4 liters of oxygen. He was 36 years old, and he and his wife were asking me some very common questions. Will I ever get off the oxygen? And am I going to end up on oxygen the rest of my life from this COVID? Am I going to have problems the rest of my life every time I get a respiratory infection or whatever? And I honestly, I didn't know all the answers to those questions. It's really can be very severe in some patients. Yet in other patients, they have very, very mild symptoms. So it's always a challenge. Now, Joe, can you go to the next slide? So this is the famous, COVID that you see on the news, courtesy of the CDC. It's the enveloped RNA virus that's caused this. And just to put this whole thing in perspective, we just recognized this at the end of 2019. Certainly there have been COVID, or there have been other coronaviruses that we've known for a long time, but this does appear to be a novel coronavirus. Currently, the scientists think that it's related to bats, or species of coronavirus that are found in bats, and they think the origin of this may be from bats because it's very similar to, distinctly related to viruses that are found in bats, coronaviruses. So, and of course, however, that type of ingestion, or that association with bats gets into human population, there's been all sorts of discussion about. Next slide. And so I'm just going to start off a little bit about the epidemiology of COVID. Next slide. So, let's talk a little bit about what really is the virus. So the official name of the virus is the Severe Acute Respiratory Syndrome Coronavirus 2. So it's SARS-CoV-2, and it's called COVID-19. And currently there's 20 million cases worldwide. Next slide. So this is from just in the last 7 days or so, maybe in the last 9 days, there's been 6,916,000 cases in the United States. We're truly leading the world in the number of cases of COVID-19. We have surpassed over 200,000 deaths in the United States, and it's pretty significant. And we even in the last 7 days, as up to last week, we've had 302,000 cases. Next slide. So this is the the graph, and remember when we kind of had a shutdown in our economy and our local areas, and that was pretty early on, right in the April time frame, and then we started to open up things over the summer, and then we had that second wave of patients in the summer. And I can tell you, practicing in the Central Florida area, this is where we saw our big wave. Just tons of influx of COVID patients over the summer. We actually had to dedicate an entire floor of the hospital to it, or almost the entire floor. I think some of the beds we didn't, but we had whole wings of the second floor of our hospital dedicated to COVID, and we're seeing a lot of patients. And I can tell you what I'm seeing here over the last month. It got down. We were actually, and I'll tell you, we only had a couple of patients in the hospital as of about 2 weeks ago, and now we're up to about I think about 10 or 11 cases in the hospital. So we are starting to see it up. And of course, what I'm seeing, here in the hospital are the sick of the sick. There maybe 10 family members at home, or with mild symptoms, and I'm seeing the really sick patients here in the ICU and on high flow oxygen, et cetera. Next slide. So the incubation period for COVID is up to 14 days. Now, almost nobody, after they've been around somebody, gets it the first couple days. So it takes about 2 days minimum for patients to start developing symptoms. But the average is about 5 days in most of the studies. So, if you go to the party on Saturday, you're probably not going to start getting symptoms till Wednesday or so. Next slide. So I'll tell you, go through some of these signs and symptoms, and I, probably at this point, a lot of people know what the signs and symptoms are of COVID. Next slide. And I can tell you that, the most worrisome manifestation that is presented, for, severe illness in patients with COVID is pneumonia. And so similar to the influenza of, 1918, 1919, pneumonia is a predominant symptom. And I can tell you that the pneumonia, it can present any lobe of the lung. It can be, very severe. It does have a tendency to be, it seems like more at the bases, but it can be anywhere. I've seen it in the upper lobes. I've seen it in the middle lobes. I've seen it in the lower lobes of the lungs. And certainly you can develop a secondary bacterial pneumonia because when that virus goes in there, it attacks the local tissues, and a secondary bacterial pneumonia can ensue. And if you remember, that was the big killer of people during 1918, 1919 COVID, or I'm sorry, the influenza, I should say, swine influenza back then. This we are not seeing quite as much secondary bacterial pneumonias, but we have seen some. But the pneumonia itself that we're seeing is mostly from the virus itself eating at the lung and also causing an inflammatory response to the lung. Next slide. So this is actually a CT scan, and you hear in the media oftentimes about a ground glass appearance. And I guess, for some people, I guess if you've ever seen, glass that's, been pulverized on the ground, that's grounded up, it kind of has that appearance on the CT scan. And that's what's indicated by the arrows of, I think it was the NIH, the CT scan came from. And this one I would say actually is a relatively, mild case of COVID-19 from what I'm seeing. So this guy, I'd say probably on average, probably walked in, which maybe just a little bit of cough, may or may not have a fever. And the chest x-ray, believe it or not, in this particular patient, if anything, it'd probably be fairly subtle, just because it's not, a lot of this ground glass changes. But you can see on the CT scan, it's there. And, I can tell you a lot of the patients I see when we do the CT scan, I mean, there's ground glass all over the place. The lungs almost turn to jelly from the combination of the virus itself eating into the lungs as well as the inflammatory response that we see as a result. Next slide. So, first thing, fever, but not everybody has fever with COVID pneumonia. I think, what I see, about 40 to 50% of patients have actually been recorded with fever. And I can tell you clinically, I mean, I have patients with the bad COVID, no fevers at all. And I also have patients with daily fevers with COVID. So it's variable. The cough, that's the one where I see quite a bit, almost all the patients I have with COVID have a cough. And it's usually this non-productive dry cough, hacking cough a little bit. We use a lot of Robitussin DM, a lot of Tessalon pearls for these patients. The dyspnea is real. Patients, that's a very common reason for patients present to healthcare providers and certainly to the emergency department in the hospital with the shortness of breath. Upper respiratory tract symptoms, which mostly is the shortness of breath and cough. And, they usually don't have a whole bunch of sputum. Sometimes patients will complain of myalgias. We also hear abdominal pain, abdominal musculature, pain as well for some reason. Diarrhea, a lot of patients do have diarrhea. Loss of sense or smell or taste. And I can tell you in the published literature, at least early on, they were saying that they were only seeing this about 10% of patients or so. But I can tell you, a much larger number of that in the patients I see. And maybe it's just because I'm seeing the more sicker patients, they're more symptomatic or whatever. That's seems to be a very common, complaint of the patients, the loss of smell or taste. There's also probably some lesser common, signs and symptoms of it. Seeing patients in the hospital, I see a lot of delirium. These patients will come in with COVID-19, especially our elderly patients, and you're treating them like delirious patients. You think some of these patients really can have to get significant support from a psychiatric standpoint, because they have a lot of mental status changes, and sometimes it lasts weeks. I've had a patient that literally we're taking care of for about 3 weeks until she finally got back to baseline from the delirium from it. Next slide. The good news is 85% of patients really don't have what I would call a severe infection, and what the literature would call a severe infection. It's only about 15% of patients, according to the published literature, actually have severe infections with hypoxia. I know they mentioned that the President of the United States has COVID-19. They said that he did have a little bit of transient hypoxia, so I guess, I don't know if he's I guess technically he's probably within those 15%. Next slide. This is probably the scariest complication of COVID. When we talk about COVID leading to being intubated or putting on mechanical ventilation, putting on the breathing machine, when we talk about patients dying from COVID-19, this is a major culprit here. And unfortunately, I've had a few patients that have had to sign the death certificates for COVID, and it was and this was and almost all of them, this was the major thing, which is ARDS. And ARDS is not unique to COVID by any chance. This is a disease that we've known about for probably 100 years or so. It's frequently a complication of infection. If you have a bad infection, bad pneumonia, if you have another infection somewhere else in the body, ARDS, or acute respiratory distress syndrome, used to be called adult respiratory distress syndrome, is the likely candidate. And that when you look at the chest X-ray, that just looks like all white out. They have, when you do this CAT scan, they have this inflammatory response to the lungs, and the lungs actually just kind of fill up with fluid in the little sacs. And the problem is, when there's just this fluid around, patients can't breathe through water, and they can't breathe through this fluid. And it's not, the surfactant in your lungs normally that does help, transmit oxygen. It's actually it's like a inflammatory fluid that patients can't breathe through, so they really can't oxygenate. These are the patients that we have to put on the ventilator. Next slide. This is a patient with ARDS, and you notice on the chest X-ray, both lungs, it looks like fluid kind of going all the way up. So this would be a patient with ARDS, and actually this patient isn't nearly as bad as a lot of the patients with ARDS. And you can see they just have a couple of telemetry wires, on their chest, but they don't have a intubation. I don't see an endotracheal tube for breathing machine yet on this particular patient. So, next slide. We're also seeing a ton of strokes, and we're seeing a ton of other thromboembolic events, such as deep vein thrombosis, pulmonary embolism. I bet you I've taken care of 30, 40 patients. I don't know, maybe I'm exaggerating a little bit, but I've taken care of at least 20 or 30 of them, I think, with with either some type of deep vein thrombosis, pulmonary embolism, or some other type of clot, including strokes that I think are truly related to COVID. Acute cardiac injury is a possibility. Where a lot of times we're checking cardiac enzymes on these patients. We're finding them to be elevated from and they could actually have a direct, what we call myocarditis, where the virus actually goes into the muscle of the heart, and they get what's called a myocarditis, and they can have chest pain associated with it. We see a lot of acute kidney injury associated with COVID-19. Some of it's just because they get dehydrated, maybe from the diarrhea or some of the other symptoms, and they end up with it. And certainly, all sorts of other inflammatory complications that we're seeing. Next slide. This is just a picture of DVT, and there's something about the virus affecting the clotting cascade, as far as we can tell, that sets off this inflammatory process. So, when we talk about giving blood thinners to patients prophylactically that have COVID-19, especially if they have elevated D dimers, it's because this is what we see. We see blood clots in legs, and of course these can go up the lungs and cause pulmonary embolism. And so you talk about one of the reasons why we send patients home that have COVID-19 with a pulse oximeter. If they have immediate reduction in pulse oximetry, I mean, it could certainly be the virus itself and maybe developing the ARDS we talked about, but they could have that clot that went to the lungs, causing a pulmonary embolism. So, something that we have to be very judicious about. And what we learned over the last, probably 8 months of really dealing with this virus, and probably 6 months of really dealing it here in America, 7 months, is that we do have to give blood thinners in patients with elevated inflammatory markers, particularly those with the elevated D dimer, because they seem to be extremely high risk for these deep vein thrombosis. Next slide. So, the families always ask me, I'll have one patient with bad COVID and the rest of the family is fine, or they have very little symptoms. So the risk factors for really bad COVID, it's cancer, chronic kidney disease, our COPD patients, those chronic smokers, chronic emphysema, the emphysemas, chronic bronchitis patients, transplant patients, although, luckily we don't have that many of those around. Obesity, I mean, to me, I think that's, should be capitalized, underlined, bolded, just because it's such a major issue. I can tell you, I mentioned, just 2 weeks ago today, I did a code blue on the guy. He died, 56-year morbidly obese guy. He was, morbidly obese, that 32-year-old woman with the kids that died, morbidly obese. There does seem to be, just as the literature, suggests, certainly a correlation between obesity and severity of COVID. Heart disease seems to be associated with the sickle cell. I had a sickle cell with COVID recently, and they can certainly have bad COVID. Diabetes certainly associated with COVID. And of course, the challenge is nowadays when they have severe COVID, we're putting them on steroids. And so, almost everybody with low oxygen levels is getting steroids nowadays. And of course, it creates a real dilemma because it increases the sugars, just like we talked about with GCA. Next slide. So let's talk a little bit about the transmission. Next slide. We do know that it's usually direct person to person. So it's, not typically from fomites. It's typically from, the mucosa. Next slide. And it's mostly through respiratory droplet spread. So any mucous membrane, such as the nose, the eyes, the ears, certainly, with your line of work, that's something we got to be very diligent and careful to recognize. Next slide. So let's talk a little bit about testing for COVID-19. And do I have next slide on this? Yeah, do the next slide. Okay, so talking a little bit about testing for COVID. And so certainly, you hear all sorts of different things like, there is the antibody test for COVID. And the problem with the antibody test, by the time you develop antibodies, that shows that you probably had it recently and doesn't show that you currently have it. I can tell you what we do here is a test that we get back in about 5 hours. Nowadays, I mean, it was taking a lot longer before. It's the PCR, which is considered the gold standard for COVID. So we get the PCR, we get the test back, certainly for our more severe COVID patients in about 5 hours. It's one of those, nasal swabs where you actually stick it up, and it's not very comfortable. Somebody sticking a swab in the posterior nasopharynx, not a very pleasant feeling. Twist it around and we send it off, and that's considered the gold standard right now for testing for COVID-19. The problem is it's a 70% sensitivity. That means that we're missing about 30% of the patients with COVID-19 with the PCR. Part of the thing is that, the virus is not necessarily in there. But when it's positive, it's positive. You got it, right? I mean, it's one of those tests that, positive test means they got it. On the contrary, negative test doesn't necessarily mean they don't have it. I've had patients. I had a patient that had 3 negative COVID tests, and it's only when we did the tracheal aspirate that they actually did have confirmed that the patient had COVID, and we knew it clinically. There are a number of different screening tests that you probably heard about out there with some varying results, but the PCR nasal swab is currently considered the gold standard. Now, I can tell you that a lot of people ask, and patients ask this all the time, can we just go ahead and do a test for cure? Can we get a test, should we get a test before we leave the hospital? And the answer is, for COVID-19 PCR testing, the remnants of the virus may persist in the nose for up to 6 weeks afterwards. And I've seen this, myself. So the problem is, if you're you got a colleague that's trying to figure out to come back to work or not, the answer is that you're not waiting around for a PCR testing. You give them the 10 to 14 days of quarantine after the symptoms develop, assuming they're asymptomatic for at least 10 days. Then you're probably good to assume that they're good to return to the workplace and normal life. Of course, telling folks to practice the same thing that everybody else does, is to wear a mask and practice wash your hands frequently and those type of things. So certainly, so I'd say that's kind of testing in a nutshell. Now, treatment. Next slide, Joe. So oxygen when appropriate, and I can tell you that oxygen is a lifesaver to the COVID patients with severe disease, and that's why I do think that the pulse oximetry can be a lifesaver. And a lot of times, I see these patients, they're walking off the street with COVID, and their oxygen saturation will be down in the 80s. Normal is about 98 to 100% normally, right? And so when you got somebody walking off the street with oxygen, pulse oximetry that's like down in the low 80s or in the high 70s, these people are in trouble, and it's amazing how many of the patients don't even feel it. So that's part of the reason why the pulse oximetry is going to become the standard outpatient instrument for sending patients home with COVID-19. And certainly in the hospital, we do a lot of continuous pulse oximetries where we're monitoring it around the clock, and we have little monitors in the room for the patient. Next slide. A lot of steroids. When we first heard about COVID, we said, well, we don't want to give steroids to these patients because it's going to increase the risk of having secondary infections, et cetera, and it may even hurt their immune system a little bit. But what we found over time is that the steroids actually decrease the inflammatory response to the COVID pneumonia or to the COVID virus itself. So by giving them the steroids, it actually decreases it fairly significantly. So so we do believe in steroids to patients, certainly patients with severe COVID-19 hypoxia. These are patients that should be getting steroids, and it's dexamethasone is the standard one that everybody's getting nowadays. In fact, there was a shortage of the 6 milligram dexamethasone, and so I think now a lot of pharmacies have to give the 4 milligrams and then 1.5 of those each day. And so we're treating almost everybody with the dexamethasone, typically 10 days for most of the folks with COVID. Next slide. We do give antibiotics, especially if they have appearance of pneumonia on the chest X-ray, because you really can't tell if it's truly just from the COVID or if it's a secondary bacterial infection with the COVID. So we do give a ton of I should say a ton of antibiotics. We typically treat them for community-acquired pneumonia, which is can be treated with a handful of different antibiotics. So in the hospital, I'll give them ceftriaxone and good old azithromycin or Z-Pak while they're in the hospital most of the time initially for these patients. And I know outpatient, that's typically how we're treating them as well. But antibiotics, and that treats the secondary bacterial pneumonia infections associated with COVID. Next slide. So the blood thinners, the anticoagulants to prevent deep vein thrombosis and pulmonary embolism, as well as other potential clots, really is very standard, and most health care systems actually have guidelines placed that any patients with elevated D dimers, the D dimers should be placed on anticoagulants. And of course, there's been some discussions, and I think that there's varying opinions about how long you put them on blood thinners, if it should be 10 days or if it should be more like 30 days for some of the patients based upon their severity. I think it varies, but certainly I can tell you if I had COVID and my D dimer was elevated, I would definitely be on a blood thinner to prevent clots. Next slide. Now, remdesivir, you probably heard that the president has received remdesivir. I can tell you that the current standard of care of anybody that's had any requirements for oxygen or are hypoxic anyway should receive remdesivir. Remdesivir is an antiviral agent that has been shown to be effective in treating patients with COVID-19 pneumonia. It prevents the worsening, of the symptoms of the infection itself. I can tell you, the cocktail that we have when patients coming off the streets, if they're hypoxic, they're going to get, oxygen level, or they're going to, obviously we check their oxygen, but we, treat them with oxygen. We put them on the steroids I mentioned. We'll check a D dimer. If their D dimer is elevated even a little bit, which many of them are, they get the steroids. They get the anticoagulants, and the remdesivir is, kind of the standard of care. It's a 5-day dosage. So, they didn't mention this, but I'm sure the president will get a full 5-day treatment. It's a IV treatment once a day of this, antiviral, and it's, been very effective. And I can tell you in the clinical studies, it's been effective. And I can tell you at the bedside, I've seen it. You give them that cocktail with the remdesivir, most of the patients do very well. Next slide. Convalescent plasma, it seems like you go through any metropolitan area nowadays, you see the billboards, if you've had COVID, please donate your plasma. The initial FDA stuff, there was some, varying results on COVID with, plasma, but there was enough compelling evidence that the FDA decided to approve it, for patients. So we do give a fair amount of convalescent plasma, and it does seem to be effective, with patients, and it does seem to affect. So usually it's usually our more severe patients that we're giving the convalescent plasma to. Next slide. So tocilizumab, may prevent death in seriously ill patients with COVID, and these are typically the patients with the elevated, really elevated inflammatory markers. It's super expensive. I think I've only given it to a couple patients, or at least a couple of my patients have it. We actually have that on a restricted formulary because it's so expensive. And we want to make sure that we're also giving it, rationally. So we actually even have it on a restricted formulary. It's, and I haven't seen that much, anecdotally, I haven't seen that much effect, but the clinical studies do show that there may be a positive effect, but it's rare that we have patients that get tocilizumab. Next slide. Things that don't work. Hydroxychloroquine, according, and this is, I think, a quote, I took it directly from UpToDate, which says hydroxychloroquine has a lack of clear benefit and potential toxicity. And, for the most part, you probably saw that New England Journal of Medicine article, some of the other studies out there that really showed didn't really make any impact. There was one confounding study from the Henry Ford system up in Michigan that, seemed to, improve outcomes a little bit. But the majority of the evidence out there showed that it did not have any effect on improving outcomes, and it certainly had some toxicity in a small number of patients, particularly with QT prolongation, which is the cardiac rhythm prolongation. So, yes, not something I would personally take. I wouldn't give it to any patients. I've, like I said, I've taken care of 200 patients here, maybe more. Not a single one of those that I know was treated with hydroxychloroquine, nor did any specialist recommend hydroxychloroquine to any of those patients, nor did any of, and surprisingly, none of the patients actually demanded hydroxychloroquine. Only a couple of patients, or a small handful of patients actually asked for hydroxychloroquine, or asked about it. So let's talk a little bit about prevention. Next slide. So infection appears to produce, immunity for at least some period of time in many patients. You probably have heard that there have been at least a couple patients that have had a reinfection of COVID. I can tell you, I believe I know of a patient that had a reinfection, but it is very difficult to prove, especially with our current technology. So it does seem to have some, immunity, and certainly if it didn't, the convalescent plasma probably wouldn't have an effect. And of course, this is good news that there appears to be some immunity, and even if some of it's cellular related immunity, that bodes well for a future vaccine. Next slide. We do definitely want to.
Hey, Robert.
Go ahead.
Hey,
yes,
I'm
sir.
going to give you a break because I know what it's like to be on that end and be rattling away. So there's a question that came in, so I'm going to let you get a chance to inhale and exhale. And then there's a question that came in that says, do you find the patients would be better with better outcomes if they'd come in sooner than they actually do?
Yeah, so the answer is I do think that patients should get checked sooner. I can tell you we've had patients that walk in or come into the hospital, via EMS, and they're literally at death's door. So I think nowadays, if you're having a respiratory illness, fevers, you're having some of these other symptoms such as the things, I think you should get evaluation. I can't tell you how many patients I've taken care of that literally walked in with very low pulse oxes, and it was actually surprising how little symptoms that they did have. So, I do think the patients should get care sooner, especially nowadays. I mean, I've had patients that they come in, they're so sick, and we intubate them and everything, and heck, if I'd just seen them a few days before, I could give them steroids, anticoagulants, supplemental oxygen. I could give them remdesivir if they were, sick enough to be hospitalized. So, 100%. And if it was me personally, I mean, I would be, getting it much quicker. Just like, the president. I mean, they're treating him pretty aggressively, and I think that we all deserve excellent care as well. So let's talk a little bit about wearing masks. Washing hands, respiratory hygiene, avoiding crowds, avoiding contact with all patients. I mean, this is nothing new to any of us, but we do know at this time, wearing masks works. Of course, you're wearing your mask to, in some ways, prevent the, virus, spread to when you, cough and sneeze, and even when you talk. There was that famous study of all those people in the choir, and they all ended up getting it, just being acquired, just because that singing or even talking, you spread the hygiene. So certainly those patients, you really want to wear a mask, but it's a two-way street. They have to be wearing masks too. And what we do know is that wearing the mask gives you some protection, but if both parties are wearing masks, you should do it. And that's why you should be wearing, should insist on your patients wearing masks when you're seeing them and examining them, in an optometry practice, washing hands, alcohol-based, solvents work. I'll tell you to wash my hands. If I had to wash my hands, as many times as I do each day, and taking the at least 20 seconds out to wash your hands. I mean, I just wouldn't have a chance to on a day that I'm seeing patients. If I'm seeing 20 patients in the hospital and I'm seeing someone multiple times, I mean, it just would be impossible for me to wash my hands. The alcohol-based stuff is a reasonable alternative for those things. But if you do have soiled hands, you really do have to wash them for 20 seconds, soap and water, drying them, well. Respiratory hygiene, coughing into your elbow, avoiding crowds, as much as possible, and avoiding contact with ill patients, which is, you'd be surprised how many people that, know the patient, is having respiratory symptoms, and, they're around them, and then they catch COVID, and, of course, there's a reason why. Next slide. So, I'll put up some slides here, and Joe will, help me on this and give his thoughts too, but I'll throw these up. Next slide. So obviously, you want to minimize close contact time with patients. Easier said than done. I mean, I got to look in patients' mouths all the time. I don't do a whole bunch of optometric or fundoscopic exams on patients, in the hospital setting. But you want to try to avoid as much as possible. Next slide. Wear a face mask and shield with patients. So, where I am, I don't see a patient without wearing a face mask and a shield. I don't do anything in public without wearing a face mask. The only time I take off my mask is when I'm at home or in my car or in a place where I'm far away from anybody else. The rest of the time I get a face mask on and a shield. If I'm with a patient with COVID, I'm wearing an N95 mask and a shield, and of course a gown as well. Next slide. So diligent hand hygiene, always washing your hands. Like I mentioned, not touching your face, not touching your eyes. Next slide. Use the same precautions around staff. And it's interesting. I see people in the hospital setting, they'll go back to the break room. These people are sitting around, COVID patients all day long. They go back to the break room and they're like, eating pizza and taking off their masks with each other, and so I think that's probably where a lot of transmission, occurs. Even in our hospital, we've had healthcare providers, which I'm not necessarily convinced that they got it from patients. I think sometimes they got it from each other when they kind of drop their guard a little bit. Next slide. And so I'll turn over for thoughts and questions and comments. I know and Joe will probably answer this more, know this more. I know that there was that controversy about, whether or not people should stop wearing contacts because they're touching their eyes. I'm sure they ask you, but guys, and there was that, that suggestion from the Ophthalmological Association about that. Now I know the CDC's come out and said, don't stop wearing contacts. And so there's a lot of different, aspects I think that, touches on, your individual practices. And so anyway, so I'll open it up if you all have any questions or comments or thoughts for me or Dr. Salka.
Well, actually, Robert, we're in a little bit of a different situation. You are on the front line. You've got people who are the sickest of the sick, and they have the disease. Realistically, we're screening people, and if there's any hint of anything wrong, they're not getting in our offices. So we're a relatively protected group. Now, that being said, you mentioned how many patients you have with bad disease who don't have fever. Our screening, I think, for most people is just simply a non-contact temperature reading on their forehead. Is there something better? I mean, should we be doing pulse ox? Is there something else that might be better to screen these people? Because mostly what we see are not that urgent.
Yeah, that's a great question. Now, I can tell you, if you look at the data, it's somewhere over 50% of patients, you're never going to see the fever, right? With patients with COVID-19. Pulse ox would be a very unreliable test just because of the sensitivity and specificity for the screening procedure. The questionnaires, for the patients, if you have any of these symptoms, turn around, don't come in type of thing. It sounds great and everything, but let's face it, these people have had an appointment for, so long, it's like, especially now, people have limited appointments and, waiting rooms and, that are kind of downsized and all this other stuff. So, patients, people, I'm not sure how reliable it is. And we do know that 85% of patients with COVID either have no symptoms or mild symptoms. And you wouldn't necessarily pick that up, right? If they have this dried, non-productive cough, when they're out in the waiting room, there's, right now, there's probably a good chance they could have COVID, but a lot of patients don't have it. So I think that you just have to live your life like, everybody's got it, and just practice these things, for right now until we get a vaccine and go from there, and certainly be careful.
And just refresh us, how many people, what percentage don't have fever, did you say? You said 15 or 50?
No, yeah. So I think that the number, and my recollection is that about, a little over 40% or 45% actually have, true fevers with it. Maybe they have a little low-grade fever. So, you're looking at like, and certainly fever itself, it's not a 24/7. Watching a lot of patients in the hospital with fevers, patients may have a fever spike. You give them Tylenol or, just various changes in the day, the fever will go down a little while, it will spike again. So, to hit them with with the temperature reading, it's good, right? It's about the best thing we have. And, and I actually go through a temperature reading every single day when I walk in the hospital. This automatic little, iPad checks my temperature and says, gives me a green thing. It says my temperature is 97.2, please proceed. It's always a little lower than I would expect, but it's, I think, coming from my car with the air conditioning on. But yeah, it's basically all you have, right? But you gotta protect yourself either way, I think.
Yeah, so it sounds like a fair number of things that we're doing is actually just theatrical. May actually not make much of a difference in identifying who has and protecting. I think the distancing and the mask wearing is pretty acceptable, but some of the other stuff, I think, leaving the Amazon package, on the doorstep for 2 days, we've gone past. It seems like we've gone past that. We've been hearing some things about the president. He's getting polyclonal antibodies, vitamin D, and melatonin, and some of that came out as a bit of a surprise. Just if you can comment on that and how beneficial is this?
Yeah, so I think that a lot of these are anecdotal. If you just go by some of the anecdotal stuff that we've seen, there's been all sorts of people doing all sorts of crazy stuff with COVID-19, and we've seen some stuff. Some of our thoughts and feelings, that have been proven wrong. Right? Initially we thought don't give steroids to these patients at whatever cost, and turns out steroids was like the best thing. Some of these things are pretty low harm, right? Zinc. I have no problem, giving zinc to patients because, giving some zinc to these patients and the dosages that they're typically giving them is probably not going to cause any harm to patients. Heck, it's sort of like the same dosage that we kind of give the nursing homes to prevent that dermatitis, nursing home dermatitis they get. So I don't have a problem with that. It may not help, but it's probably not going to hurt. This artificial, antibody that the president's got, this kind of experimental therapy. I don't know. It's not an FDA approved thing. I don't think we have enough literature to really say that it's a proven thing. It's interesting. It's not the first president of the United States that has used an unapproved treatment, for their medical condition. People forget that back in 1951, President Eisenhower had a heart attack, and he basically demanded to get treated with Coumadin, or back then, the generic was warfarin, before it was even FDA approved for his heart attack. So, So it's not completely unprecedented that the ruler of the most powerful nation in the world gets experimental treatments. But I don't know. I mean, I think certainly not. Something that you never want to be the first patient nor the last patient to ever do something, right? So I think that we have to do it with a grain of salt. And some of the other stuff, I mean, I don't know. I mean, melatonin and also, who knows? I mean, it's melatonin's, I don't think anybody ever died of taking a little bit of melatonin, so it's probably not going to hurt anything. But we got to be careful with some of the other stuff that's out there.
We chatted about that, Joe, Tracy, and I, as you guys know. Robert, I think you might have met Tracy. She's the pharmacist, and she said the biggest thing about that, if you're trying to get a good night's sleep, is at least it doesn't cause any respiratory, and obviously you don't want to do that if someone's having a lung problem. At least that was her thoughts on the melatonin in a recent recent CE that we did. The question I have out there, and this could be for Joe or you, Robert, is what type of eye findings are we seeing with this? I mean, I'm in this pandemic. Luckily, I'm not in an epidemic area, so I don't have a lot of patients coming in. Is it conjunctivitis? And with this type of blood clotting, are people getting CRAOs or BR, branch or venous occlusion or artery occlusions with this type of condition in the end stage? What are we seeing eye findings, I guess, or don't we know?
Well, I think, Greg, the answer is we don't really know. I've not heard artery vein occlusions very much. There have been some small studies in patients who are hospitalized, and they've had things like conjunctivitis, epiphora. I have been seeing a fair number of conjunctivitis that don't really ascribe to anything other than maybe a virus. It kind of shakes my faith in what we're doing, that if we're trying to prevent COVID infection and somebody comes in with the adenoviral conjunctivitis, I'm getting a little bit worried that all we're doing might be theatrical. That kind of makes me a little bit nervous. Now, there have been a lot of things reported through the ODs on Facebook School of Medicine, and I'm not really sure if it's COVID or COVID incidents, just a coincidence in the COVID times. But it seems like everybody wants to blame everything on COVID right now. But maybe some of these viral conjunctivitis and epiphora, lacrimation, hyperlacrimation, and these are things that have been seen in COVID patients.
Robert, thanks, Joe. And Robert, have you seen anything on your end? Just kind of curious, anything going on with the eyes?
Nah, I mean, I had this lady that actually, we don't really take care of, too many retinal artery, occlusions and stuff like that. But did have this lady that, that we actually, were able to get an inpatient consult for, and who knows if it was or just a coincidence or timing wise. I completely agree with Joe. Everybody wants to blame everything on COVID right now. And it seems like every stroke that we're taking care of inpatient, people always want to blame it on the COVID, and every pulmonary embolism, everybody wants to blame it on COVID. I just had this young lady that had a really bad pulmonary embolism, and people forget sometimes that we had all these things before COVID too. So not everything's related to COVID. So I completely agree.
Well, we've only had one question roll in the chat box. I thought we'd get a lot more questions roll in, but that's fine. That means you did a great job, Robert. Joe, it looks like we're about 8:50. Do you want to do any closing comments? Do you want to take it in a different direction? Where do you want to go right now?
Well, really what I want to do is thank Robert for doing this. It's really an honor and a treat to get a friend and colleague who has a different training and different perspective come in here. And, Greg, you and I can talk about this from a theoretical approach, but to hear from a frontline operator and a person who is actually treating these patients, it helps cut down and cut through some of the, I think, misinformation that we hear all the time. So I can't thank you enough, Robert, for doing this and giving the insights that you did, because it's really truly unique.
And thank you, Dr. Salka. It's such an honor and pleasure. And I so appreciate the time with you, and as always, and I appreciate all the incredible work that the optometrists and the profession do, and I think it's great that we can do more of these things in the future. So thank you for the honor and pleasure.
And before I do a few little housekeeping here things, I'm just going to echo what Joe said here, Robert. It's always, we work together out in Scottsdale, and this was, unfortunately, these are the times that we have to do it this way. So, having someone that's in the thick of things, it's, truly an honor to have you here tonight. So thank you for taking time out of your schedule and being here with us.
Thank you. Thank you so much.
So, yeah, Robert, I'm just going to do a couple of housekeeping things here. If you want to jump off, that's fine. If you want to stay in, that's fine. When we end the meeting, that we don't go back to the waiting area. So, so if you want to log off, that's fine. I'm just going to remind everyone that there will be an email certificate emailed to you. Vanessa is our conference administrator. I will take care of who attended tonight. I'll probably have that to her tomorrow. She'll get it off to Arbo, and then it takes about 7 to 10 days. Again, Arbo is backlogged with all the webinars, so no fault on their end. We're glad that they're allowing us to do it this way. And then Vanessa will email your certificate to the email that you used tonight to register. So that's just the housekeeping that I have, and I just want to thank everyone for coming. Joe, I'll let you close it up.
All I'm going to say is, after we've heard that excellent presentation on COVID, think about what he said. Be safe, be secure. We're all going to get that. We're all in this together. We may not be in the same boat, but we're all in the same storm. So we'll all get through this together. Be safe, and we're looking forward to seeing everybody on the other side.
Okay, everyone. Thank you. Take care. Be safe.